Welcome back to The Wellness Effect. This week we are discussing breast cancer. As always, hit the subscribe button to avoid missing out on any of our discussions. With me in the studio is Dr. Yonita Singh, a trailblazing surgeon. Welcome, Dr. Singh.
Thank you.
It's a pleasure to have you here today.
Thank you so much.
So maybe tell us a bit about breast cancer.
So essentially, breast cancer develops where cells of the breast, they start to grow, they change, and ultimately they abnormally divide. Now, when they abnormally divide, what happens is they start to form tumors. Now, tumors can sometimes be palpable, meaning you can literally feel a lump, but sometimes that's not always possible. So you can still have breast cancer
Sure.
within the breast, but have a very small lump or a very early lump that is in fact only picked up on screening investigations.
Okay.
So if we actually look at breast cancer in itself, in South Africa, if we look at the statistics, 1 in 27 South African women will get breast cancer in their lifetime. So that sounds quite high.
Hmm.
And actually, that can even go higher if you have a genetic or a family risk of that. So ultimately, breast cancer still tops the charts in terms of cancer related deaths worldwide, and even in terms of the top 5 cancers in women. So if we look at that, breast cancer definitely number one, followed then by cervical cancer, colorectal cancer, uterine cancer, and then lung cancer. So that's why it's really of utmost importance to get to know about breast cancer.
What are the myths surrounding breast cancer? I hear a lot of the times we focus on the female. How about guys?
So it's good that you bring that up. Often we do see males with breast cancer, and very important, there's quite a few other myths. So the first one is, I'm a man, I
Yeah.
can't get breast cancer. And honestly, that actually isn't true. We do find that in females, it is way more common, like we just said, 1 in 27, versus in males, it's about 1 in 900 to 1,000. So yes, it's way less common. But what we find is when a man has a breast lump, it's often overlooked. So
Hmm.
oftentimes it's thought not to be a cancerous lump. So, yes, they go to clinics, they go to the GP, or sort of just ignore the diagnosis until it's actually quite too late when they present to the surgeon and that lump is actually advanced or spread to other organs already.
Hmm.
So, that's one of the problems we do see. The other one is I'm too young to get breast cancer. And the opposite is actually true in clinical practice. We do see a lot of patients under the age of 40 getting breast cancer. Previously, it was just thought to be a disease of over the age of 60 or 70, but honestly, that is no longer true. The other one is I don't have a family history of breast cancer, so I'm probably not going to get breast cancer. And ultimately, only 10%, maximum 15%, are in fact hereditary, meaning 9 out of 10 patients diagnosed with breast cancer actually don't have a family history.
Hmm.
And then, probably the last one, but also quite important, is patients think, okay, I haven't had kids yet, or breastfeeding. What is the situation there? So, breastfeeding is thought to be protective actually against breast cancer, but ultimately delaying fertility or having children. So, what we usually find is nulliparous women, so patients who have not had babies yet, or you delay it to after the age of 30, you actually do have an increased risk of breast cancer.
And what are the risks of developing breast cancer?
So when we look at risk factors, generally you want to look at what are risk factors that I can control, so things
Sure.
I do have control of, or things I cannot control. So let's look at the uncontrollable risk factors, so things you can't really change. So firstly, we discussed age. Yes, it
Yes.
does increase. So above the age of 40, the incidence does increase. So of
Okay.
course, there's nothing we can change about that. Being female, like we just said, being it's more common in females than males. The other thing is genetics. So if you already have a predisposition, so say you've got family members who have genes, the common one everyone knows is the BRCA, so BRCA1, BRCA2. Yes, that predisposes you to breast, ovarian, prostate, and many other cancers, in fact. But again, we can't change genetics. And if you do have that family history, it's actually worth getting those genetic tests.
Hmm.
The other thing is if you've had previous radiation to the chest wall area, that can predispose you.
Sure.
And then, very important, is something we call a long exposure time to
Yeah.
estrogen. So, in other words, you've got your periods very early, so before the age of 12, and then you've gotten menopause quite late, so after the age of 55. So generally, we talk about a long exposure time to estrogen. So
Hmm.
ideally, that also increases your risks. Then we look at things that we can actually probably change.
Yeah.
And most importantly, that would be to avoid unnecessary hormonal medications. So before you take hormonal birth control or hormonal replacement therapy in menopause,
Hmm.
rather seek help from your doctor. Look at your risk factors for cancer. Do you
Hmm.
actually need that treatment? Are there any alternatives? And then we need to look at lifestyle. Very important, especially in 2024. Life is busy, things are hectic, but we need to focus on things like avoiding becoming obese or overweight, living a healthy, balanced diet, avoiding processed foods, avoiding excessive alcohol intake. So these are just some of the small things we can probably change along the way, but ideally, a lot of the times we don't have control of that.
Hmm. And how do we detect breast cancer early?
So, in terms of early detection, so I'm sure you've heard the saying early detection saves lives. And
Yes.
ideally, that comes in really well with breast cancer. What we're trying to look at is how do we pick up this disease early enough so that actually we can aim for 100% cure. And ultimately, the first thing is it begins at home. First thing is self breast examination. Very important for women and for men to examine their own breasts. Now, you can go on the internet, there's multiple YouTube videos showing you how do you examine your breast. In what position should you stand, sit, lie? Should you do it in the shower while you're lying on a bed? Things like that. What motion do you examine your breast in? And then ultimately look at your breast in a mirror. Have things changed? Have things become asymmetrical? So,
Mm.
very important is self breast examination.
Mm.
Then we look at identifying your risk factors. So you need to understand what are your risk factors, get to know your family history, inquire about things. And like we just discussed some of the risk factors, you can go through that and see, do I have any of these? When should I make an appointment with my doctor?
Sure.
And then discuss these options with your doctor. When should I begin a screening program? Because it's important that not all patients will begin a screening program at the same age. The recommended guideline is 40, but some patients might need it earlier, like at
Mm.
35. If you have a BRCA gene, for example, those ones we spoke about, you might need to begin as early as 18. So
Mm.
there's defined clinical screening programs, and that's obviously something we need to discuss with our
Mm.
general practitioners. And then it's really our responsibility, to stick to that screening program, know what imaging is best. For example, if you're under 35, a mammogram is probably not the best because you've got dense breasts. So then we look at something like an ultrasound, something like an MRI. So there's always other options. We
Yes.
just need to present to the doctors early enough, let them refer us early enough, and then ultimately stick to your screening program. So if
Yeah.
they did find something abnormal, probably follow that up. Or if they say come back in 6 months, you need to come back in 6 months.
Mm.
Or you need to sort of take charge of your health and understand, what am I dealing with and when do I need to follow up that risk.
Mm. And what are signs of breast cancer?
So if we look at signs, the point is, like I mentioned earlier, some tumors won't be palpable.
Yes.
So when in the rare occasion that it is, which most of the time patients palpate a lump. So a lump is generally what we first see. The other thing is examining your breast in front of a mirror where you start to notice asymmetry. So yes, both
Mm.
breasts will never look the same, but
Yes.
if has sort of evolved over time, that's quite important
Mm.
to look at. And then we look at subtle changes. So, yes, there might be a lump, but are there subtle changes like skin changes around it? Skin retraction, skin dimpling. Look at the nipple area and the areola area. Is there maybe like a new skin rash that has all of a sudden developed? Has the
Mm.
nipple maybe all of a sudden inverted itself? Have you now got retraction of the nipple? So,
Mm.
things that have sort of evolved over time. These are just some subtle signs. Things like
Sure.
nipple discharge is not common actually in breast cancer. So, you can't wait for extensive sort of signs before you present. So if you have sort of any change, it's best to get it checked out.
Mm. And how do we diagnose breast cancer?
If we look at the diagnosis, it's quite complex. It's really multifocal. And the first place it really begins with is a clinical examination. And that will be generally by your general practitioner, who will then refer you to a surgeon. So, for example, in the center I work at, we generally do this on a multidisciplinary basis. So, what we'll start with is a clinical examination. So, again, we're examining the breast, we're trying to locally stage the tumor, and then we're looking at where is it spread. So, the first place we examine is actually the armpit region. That's generally the lymph glands, which will start to swell. Then ultimately, what we want to do is get a tissue diagnosis and an imaging. So we first like to do imaging just to prevent later complications of the biopsy itself. So first we get imaging. So generally, if you're under the age of 35, we opt for an ultrasound or an MRI. Above the age of 35, because of the breast being less dense now, we do a mammogram.
Okay.
And then at the time, we look for suspicious features of that lump. If it does look suspicious, we grade it high enough and high enough that it will warrant a biopsy.
Mm.
So when you get a biopsy, there are various techniques. We don't need to jump into that. But the point is, the biopsy will generally be done by the radiologist at the time. There's different ways to do it, but what we need is tissue. And
Mm.
that's how we're going to get the ultimate diagnosis of this breast cancer.
Mm.
We're going to send it off to the histopathologist, and he's going to come back and tell us, okay, what type of cancer are we dealing with? What receptors is this expressing? In other words, what treatment options do I have later on? Is it hormone receptor positive or not? And also, it can actually guide how rapidly those cells are dividing. So that gives us a good overall impression of that cancer. Then we need to look. We've done local staging. How do we actually distance stage the tumor? We talk about metastases or spread of the
Yes.
tumor. So, where does it spread to commonly? It will be bone, lung, liver, brain. And that's what we're looking for. We're trying to see where's it spread. And that we'll do in the form of a CT scan, a CT staging. So, from the brain all the way down, or something called a PET scan as well. But all we're trying to do is highlight what final stage of the diagnosis are you in, and that will impact the management.
So, Dr. Singh, you mentioned that you might not always lose the breast. Could you talk about the other options that are now available?
So, what we try and do is avoid what we previously used to do a lot of the time, where we previously used to just do a mastectomy, so removing the entire breast as well as all the glands underneath the armpit. What we're trying to do now is less. So, how we do that is sometimes you actually don't have positive glands underneath the armpit already. So, what we do in theater is we then sample those lymph glands. And in fact, if they already turn out to be negative, we don't proceed to clear all of that. As we know, in the long run, removing all of that can result in a swollen arm, etc., in the long run. So we're trying to avoid those sort of complications. The other thing in terms of the breast itself, without removing the entire breast doesn't mean we're not removing the whole cancer. Sometimes we have targeted ways of removing just the lump and a good enough margin so that we know we've cleared the cancer. So just doing a lumpectomy is what we call it. Sometimes you might then need radiation afterwards. But the other thing is, even if we do a mastectomy, meaning removing the entire breast, we sometimes combine our surgeries. And actually, more often than not, we operate with plastic surgeons. And what we can do is reconstruction, either at the same time, be it with silicone implants or expanders. Sometimes we do it in a one stage or a two-stage process. But the point is, you will never be flat chested. So it is 2024, and ultimately, we have so many more options to treat breast cancer.
So, Doc, when you get an analysis from the lab as a patient and the diagnosis is a triple negative, what does that actually mean?
So, triple negative is actually, we're seeing it more commonly, especially in the younger population. It just means that all those receptors that we've tested for are actually negative. So, the receptors commonly are the estrogen receptor, progesterone receptor, and the HER2 receptor. It just means that all those three are usually negative, and generally that means that is a rapidly dividing tumor and a more aggressive tumor.
Mm,
So, in that instance, it's very rare that we will operate those patients upfront. Even if it's a very small tumor, we'll actually opt for more aggressive therapy from the get go, because remember, now your treatment options later are limited because those receptors are negative. So
sure.
you can't block the hormones later. So upfront, you want to actually target that treatment with chemotherapy and then later on reassess and decide on the appropriate surgery.
Dr. Singh, thank you for such an informative but also engaging conversation. We wish you continued success in your work.
Thank you so much for having me.
It's an absolute pleasure. Thank you for watching. Remember to subscribe so you don't miss out. I'll see you next time on The Wellness Effect. BankMed, the medical scheme of choice for the financial services industry. The Wellness Effect is proudly brought to you by BankMed, yours in good health. Excellent. Thank you for such an engaging and informative conversation around breast cancer. May you have continued success in your work.
Thanks so much.
Welcome back to the Wellness Effect. This week we start our series on breast cancer. Remember, if you've missed any of our previous episodes or want to follow our current series, you can head over to our YouTube channel. With me in the studio is Dr. Yonita Singh, a trailblazing surgeon. Welcome, Dr. Singh. Dr. Singh, thank you for such an engaging but also informative conversation today.
Thanks so much for having me.
It's a pleasure. There is so much more to talk about when it comes to breast cancer, and we'll be continuing this discussion. If you'd like to join us, visit our YouTube channel where we post all the full-length episodes. Bye for now.